Anatomical Principles of Endoscopic Sinus Surgery, a step by step approach by Renuka Bradoo. Surgical Anatomy. At what point then is the approach of danger to be expected? Abraham Lincoln. 7. Surgical Anatomy. This chapter is a summary of facts discussed in this book and their relevance in the milieu of the operating theatre. Endoscopic diagnostic endoscopy. The turbinates and septum are very sensitive to touch. It is therefore necessary to get good decongestion and anesthesia of the nose prior to attempting diagnostic endoscopy. Endoscopy should be done in such a way so as to avoid touching the septum and the turbinates during the passes. The second pass can prove to be the most difficult as the sphenoethmoid recess is a narrow niche. The septum. In case of a deviated nasal septum or a nasal spur, diagnostic endoscopy should be done in the roomy nostril first so as to gain the patient's confidence prior to attempting endoscopy in the narrow cavity. A very common site for mucosal trauma and subsequent adhesions is on the opposing surfaces of the septal spur and the inferior turbinate. Special care should be exercised to prevent trauma to these operating mucosal surfaces. Olfactory fossa. The olfactory fossa is the most often symmetrically bilaterally. In case of a break in the horizontal portion of the cribriform plate, the meninges may descend into the upper recesses of the nasal cavity. The olfactory fossa will appear asymmetrical on coronal CT scans. This is called the gyrus rectus sign and is indicative of the site of breach in a case of CSF rhinorrhea. The olfactory nerves pass through the cribriform plate to reach the nasal cavity. These foramina may appear like breaks in the detailed 1 mm coronal CT scans which may be taken to locate a site of CSF leak. This fact should be borne in mind when hunting for a CSF leak. Lacrimal apparatus. The lateral wall of the nasolacrimal duct is formed by the frontonasal process of the maxilla, which is thick bone. The medial wall, however, is formed by thin bones, namely the descending portion of the lacrimal bone and the lacrimal processes of the inferior turbinate. Thus, contrary to common belief, the nasolacrimal duct can be injured without encountering thick bone whilst widening the maxillary ostium anteriorly. The lacrimal bone articulates superiorly with the frontal bone, which is very thick. Therefore, in exposing the upper portion of the lacrimal sac, one may need to use a drill on this bone. The lacrimal fossa does not extend backwards beyond the lacrimal bone. Hence, in endoscopic dacrocystorhinostomy, one needs to operate anterior to the uncinate process, and it is therefore not necessary to remove the uncinate process. Since canalization of the nasolacrimal duct is not complete till after birth, regurgitation of tears is common in infancy. This problem does not need to be addressed surgically in most cases. A rare anomaly of the lacrimal system is the oblique facial cleft, in which the maxillary process does not fuse with the lateral nasal process, and thus the nasolacrimal duct is not formed. The uncinate process. The upper part of the uncinate process is hidden by the attachment of the middle turbinate. Therefore, an uncinectomy by any technique does not remove the uppermost portion. It needs to be removed separately with a ball probe or forceps while dissecting in the region of the frontal recess. In a hypoplastic and laterally rotated uncinate process, the infundibulum is very shallow. If unsenectomy is done with a sickle knife, in such a case, it is easy to traverse the infundibulum and enter the orbit accidentally. It is not necessary to remove the entire uncinate process in all cases. For example, only the horizontal part of the uncinate process needs to be removed if there is an isolated disease of the maxillary sinus. Middle turbinate. At least two of three attachments of the middle turbinate, namely the anterior and posterior attachment, should be preserved to maintain its stability. Preservation of the lower border of the ground lamella also helps to keep the middle turbinate stable and prevents its lateralization. The middle turbinate should be manipulated very gently as it attaches directly to the cribriform plate. A forcible attempt to medialize the middle turbinate in order to get a better view of the middle meatus may lead to a break in the cribriform plate and a CSF leak. While dissecting in the region of the frontal sinus recess, care should be taken to maintain the mucosa of the middle turbinate. If the mucosa of the anterior attachment of the middle turbinate is stripped off, adhesions will form between the lateral nasal wall and the upper attachment of the middle turbinate. These adhesions will cause lateralization of the middle turbinate and obliteration of the frontal recess with subsequent iatrogenic frontal sinus disease. In extreme cases, complete obliteration of the middle meatus may occur. Preserving the posterior attachment of the middle turbinate to the perpendicular plate of the ethmoid protects the sphenopalatine artery as it exits from the sphenopalatine foramen just above and behind the posterior attachment of the middle turbinate. While opening an concha bullosa, care should be taken to maintain the mucosa over its lateral surface so as to prevent adhesions developing between the two opposing row areas. Bulla ethmoidalis. Clearance of the bulla, anterior and posterior ethmoid cells should be done using the side of a straight or upward biting forceps and not the tip in order to prevent accidental injury to the lamina papyracea and orbital contents. The anterior wall of the bulla lies just in front of the anterior ethmoidal artery at the base of skull. Thus, if the bulla is kept intact during dissection in the frontal recess area, the risk of bleeding from the anterior ethmoidal artery is minimized. Minimal inflammation in the osteomeatal area can block off aeration to the anterior ethmoid, frontal, and maxillary sinus, leading to infection in them. This concept is the basis of mesenchymus functional endoscopic sinus surgery, whereby the clearance of this area alone may reverse changes in the drainage sinuses. Maxillary ostium. The normal maxillary sinus ostium lies deep in the infundibulum, very close to the attachment of the uncinate process to the lateral wall. If the entire width of the uncinate process is not removed, the normal ostium can be missed during dissection. This leads to the missed ostium sequence and recirculation of mucus. The presence of accessory ostia also leads to recirculation of the mucus. The mucus is also transported out of the sinus through the normal ostium and re enters the sinus through an accessory ostium. This recirculation of mucus can be prevented by joining the normal ostium with the accessory ostium so as to get one large opening. The normal ostium should be widened in an anterior inferior direction at the expense of the anterior fontanelle to prevent injury to the nasolacrimal duct, which lies 5 millimeter anterior to it. The lamina papyracea and the orbit lie just above the maxillary ostium. Hence, if for some reason the normal ostium cannot be located, it is safest to probe for the maxillary sinus ostium just above the inferior turbinate. The probe should be directed in an anterior inferior direction. This would prevent accidental entry into the orbit. A branch of the sphenopalatine artery runs along the lateral nasal wall in the middle meatus. This branch may be encountered whilst widening the maxillary ostium posteriorly. Frontal recess. The path of drainage of frontal sinus depends upon the mode of attachment of the uncinate process. If the uncinate process is attached to the cribriform plate, the frontal sinus drain will to the infundibulum. If the uncinate process is attached to the lamina pepracia, the frontal sinus drains medially to the infundibulum. In such a case, the infundibulum will be lead up to into a blind recess, the recessus terminalis. The dome of this recess has to be removed before the frontal sinus can be entered. This has been described by Stambergers as uncapping the egg. Care should be taken to direct the probe laterally as the thin vertical lamella of the cribriform plate lies medially. Whilst dissecting in the frontal recess, the surgeon may think he has entered the frontal sinus, when in fact he is within a frontal cell. It is necessary to de-roof this frontal cell so as to reach the frontal sinus and establish its drainage. When a supraorbital cell is present, the frontal recess will show two openings. In this case, the medial one is the frontal sinus opening and the lateral one is the opening of the supraorbital cell. When the frontal sinus drains medial to the uncinate process, its secretion do not traverse the infundibulum. Thus, infection from the frontal sinus would not normally spread to the maxillary sinus and vice versa. However, if the frontal sinus drains laterally to the uncinate process, its secretions pass through the infundibulum, making the maxillary sinus prone to infection. Thus, the frontal recess is viewed from below with an endoscope. The opening of the frontal sinus can be seen in the anterior limbs of the frontal recess. We have to look around the corner of the frontal break in order to view the inferior interior of the frontal sinus. This is best done with the 70-degree or 45-degree telescope or by hyper-extending the head with using a 0-degree telescope. Ethmoid air cells. The anterior ethmoidal air cells are variable in number. The posterior ethmoidal air cells are fewer and larger. The ground lamella should be perforated slightly medially and inferiorly in order to enter the posterior ethmoid air cells. This will prevent accidental entry into the orbit. As the surgeon dissects posteriorly, he must learn to recognize the posterior most pyramidal ethmoidal cell. He must then change the direction of the surgery inferior medially to access the sphenoid sinus. If he continues to dissect through the posterior wall of the posterior ethmoid, he would enter the cranial cavity. Lamina pepracia. A breach in the lamina pepracia anteriorly may not cause major damage because a pad of fat separates the medial rectus from the lamina pepracia. Posteriorly, however, the medial rectus is in close relation to the lamina pepracia and therefore is more prone to injury. After the lamina pepracia is cleared of cells and the maxillary ostium is widened, a ridge can be delineated and extrapolated backwards. This ridge can be used as a landmark to open the sphenoid sinus. Sphenoid sinus. Differentiation between the posterior most ethmoidal cell and the sphenoid sinus is the most common difficulties faced by the novice endoscopic surgeons. The following points help to remember the sphenoid sinus. The sphenoid sinus is globular in shape like the inside of a pot. The posterior most ethmoid cell, on the other hand, is pyramidal in shape and tapers to an apex posteriorly. The sphenoid sinus opens inferior to the maxillary ridge mentioned above in a more or less axial plane. The posterior ethmoid cells most often open above the ridge in a coronal plane. The roof of the posterior choana and the posterior end of the septum can be used as landmarks to identify the normal sphenoid ostium and then widen it to open the sinus. The ostium lies close to the roof of the sphenoid sinus. Therefore, it is safest to widen the ostium in an inferior direction along the anterior wall. A branch of the sphenoid palatine artery runs across the anterior face of the sphenoid to reach the septum. This may be injured during widening of the ostium. This bleeding is safely and effectively controlled by using a monopolar suction cautery. Another technique is to raise a mucosal flap along the artery with the artery and nibble away only the bone of the anterior wall so as to prevent damage to the artery. Since the skull base slopes downwards from anterior to posterior, its lowest level is the roof of the sphenoid. This fact should be borne in mind while clearing the cells of the ethmoid fovea. There is a great deal of unnecessary nervousness on the part of the beginner in approaching the sphenoid sinus laterally through the posterior ethmoid cells. If a curved bolt probe or suction is used to probe inframedially through the posterior ethmoid cell, this instrument can go only in one of two areas, that is, either the sphenoid sinus or more anteriorly into the nasal cavity. A more common mistake by a beginner is to probe more anteriorly and therefore re enter the nasal cavity itself instead of the sphenoid sinus. This can be easily rectified by probing in an inferior direction in a more posterior cell. Thus, if the direction of dissection is strictly inferior medially, it is not possible for the surgeon to damage any vital structure or to accidentally enter the cranial cavity. The risk for these mishaps exists only if the surgeon dissects in a posterior or superior or lateral direction. In approximately 6% of cases, the bone over the optic nerve may be dehiscent, and in approximately 25% of cases, bone over the internal carotid artery may be clinically dehiscent. This may be difficult to visualize on CT scan if the sphenoid sinus is full of polyps. Therefore, extreme caution has to be exercised in pulling polyps out from within the sphenoid sinus. Anterior and posterior ethmoidal arteries. The orbitocranial canal may have bony dehiscence 40%, which leave the anterior ethmoidal arteries exposed to the risk of trauma. The point at which the anterior ethmoidal artery perforates the lateral lamella of cribriform plate is the thinnest part of the anterior base skull, 0.05 mm. The underlying dura is also strongly adherent to this area of bone. Thus, this region is particularly vulnerable to iatrogenic CSF leaks. Patients with deep olfactory fossae with long lateral lamella, Kiros type 3, are at greatest risk. However, as mentioned earlier, shallow olfactory fossa can also be vulnerable to injury as the lateral lamella is more horizontal in orientation and therefore more easily accessible to the tip of the advancing forceps. Viewed from the side of the orbit, the anterior and posterior ethmoidal arteries enter the nose at the level of the suture line between the frontal bone and the lamina pepracia. The distance from the anterior lacrimal crest to the anterior ethmoidal artery is 24 mm. Anterior ethmoidal foramen. From the anterior ethmoidal artery to the posterior ethmoidal artery is 12 mm. Posterior ethmoidal foramen. And from the posterior ethmoidal artery to the optic nerve is 6 mm optic foramen. Sphenopalatine artery. Sphenopalatine artery can be approached through the posterior part of the middle meatus by detaching the middle turbinate from the ethmoidal crest so as to access the sphenopalatine foramen. Thank you. In conclusion, this is really for my junior colleagues and for all those who are starting out in endoscopic surgery, testing the waters, so to speak. One often hears of the learning curve in endoscopic sinus surgery. I think of the four lamellae the surgeon has to cross during surgery as the four stages in his learning curve. He first learns to do diagnostic endoscopies and possibly just an uncinectomy. Having developed hand eye coordination and some knowledge of the anatomy, he would then breach the anterior wall of the bulla to operate on the anterior group of sinuses. Once he has gained enough experience, only then should he breach the ground lamella to operate on the posterior group of sinuses. This is because the complications arising from the surgery on the posterior group of sinuses are far more debilitating as compared to those in the anterior group of sinuses. Having mastered surgery in the posterior group of sinuses, the surgeon would then venture beyond the sinus boundaries to the orbit, the cranial cavity, and the pterygopalatine fossa. We all trace our own learning curve. The important thing is to recognize that it exists and that to ignore it or to jump it would be, to quote, disaster. However, if we combine a sound knowledge of the subject with meticulousness and patience, the results will definitely be gratifying for our patients. Thank you.